Excellent. So I'm going to now speak on pediatric elbow nightmares, and definitely two tough acts to follow. But I want to chat with you. And just imagine that you saw these cases in your next week. Think of what your diagnosis would be. Think of what your plan would be for these cases. You know, would you mobilize them? Who would you call? When would you want them seen? Case one, neurovascularly intact kid who injures his elbow. Okay, we'll start with an obvious one. Okay, case two. Kid who falls, 5-year-old falls, injures elbow. And they're all isolated injuries, neurovascularly intact. These are really kind of x-ray diagnoses to think about. Case three is a 4-year-old who fell, injured elbow. These are all cases from our hospital. Case four, 11-year-old fell, injured elbow. Case five, 11-year-old that I saw emerge, fell, injured elbow. Case six is a 3-year-old, fell, injured elbow. And finally, case seven is an 11-year-old who fell and injured his elbow. Right, so let's go through these. Because I'll tell you, when we look at pediatric elbow injuries, we yesterday had the opportunity, the honor of giving you a few rules, a few sort of pearls. Here's 3 pearls for pediatric elbow injuries. Number 1, be careful. Number 2, don't rush. And number 3, be careful and don't rush. So take your time. Like again, it's fast track. We all want to be the fast talk, all that stuff. If there's one place to put your foot on the brakes and slow down, it's kids and elbows. A, because they're a little difficult to manage and treat sometimes. B, because the imaging is a little tricky when you look at all these ossification centers. C, they're uncommon injuries, and if we miss them, they're way more difficult to manage. So we'll try to walk you through some of these pearls and things to look for. We talked yesterday about sort of the importance of imaging, and the main view is the lateral view. You need good lateral views of the elbow. We'll talk about that. You need to be able to look for an effusion. But you know, even though the main view is the lateral view, the other views are helpful. Don't ignore the other views. The main things that we think about are supracondylar, right? That's like 70–80% of kids' elbow fractures are supracondylar. But guess what? There's 20% filled with other things that are uncommon and are commonly missed. You know, we think of pulled elbow, and that's kind of our differential typically, a supracondylar / pulled elbow. But there's more to think about. And just keep in your back pocket that you have the option, if you're not sure is that normal or not, of x-raying the opposite side. So I see a fair number of kids with elbow injuries and emerge. I certainly see a whole bunch of them in the fracture clinic. And I'll x-ray the opposite side maybe every like 3 or 4 months. That I'll take a kid and have to x-ray the opposite. So don't feel like it's a routine that you have to do. But if you're questioning it, you're in doubt, don't just sort of Google 11-year-old kid elbow, because the ossification centers can be off by a couple of years. But left side should be within about 5 or 6 months of the other side, the opposite side. So a much better indicator is not trying to look for a generic same age group elbow, but taking an x-ray of the opposite side. I think we all know about looking for an elbow effusion. So what's normal? So this is abnormal. You get an anterior sail sign. Normal is a little small fat pad, but when it has a triangle, it may be hard to see, but there's a triangle there. The presence of a posterior fat pad is abnormal. On good lateral views of the elbow in children, a line through the anterior humor should go through the middle third of the capitellum. It's called the anterior humeral line. When kids fall, 90% of supracondylars are hyperextension. So what happens is that distal fragment tends to get angled back. So if the line just goes through the anterior third, there's a little bit of angulation. If it doesn't touch the capitellum, that's typically going to be surgical. And then don't forget the radiocapitellar line. If you see this in adults, you see a dislocated radial head. I think we all think of like Montegia as an ulnar fracture. In kids sometimes, the bone's pretty elastic. Sometimes they can actually just like bend the bone, pop out the radial head. But don't forget that the radiocapitellar line. But if you see somebody, we all know if you have a traumatic elbow fusion in a child, you don't see a fracture, treat them for a fracture because as this child has, they have an occult supracondylar. There's a little bit of periosteal reaction you can see at week 3 that wasn't there initially. So we all got that. One thing to realize, and there's the left, the one on your screen left as well, labeled as left, that's a normal anterior fat pad, that small little pillow just on the inside there of the L. And then there's the abnormal side. What you're looking at, I used to think that that triangle that I was seeing in the posterior fat pad is the blood. It's not, it's actually the fat. And the blood is coming from up underneath. And what it does is it pushes the fat pads out. So it didn't really change my management of things, but just realize though that what you're seeing, that black is the fat. This is an obvious supracondylar fracture. Like this is called a type 3 where it's knocked right off. The one thing I don't like about this is an obvious injury. You know, like the obvious ones, the history and the physical and the x-ray tell you it's wrong. You can look at the soft tissue swelling on the lateral view. This child should not go to x-ray without some form of immobilization. If you have somebody with a clavicle fracture, wrist, elbow, anything, give them a sling at least to go down. This kid, forget a sling. Don't try to get their arm at 90. You know, we like elbows at 90, not these. If you ever see this, the kid likes his arm here. Why? Because that's where it hurts the least. This hurts more, this hurts more. Leave their arm there. Pad the hell out of it, put some kind of a splint, speed splint, plaster, fiberglass, it doesn't matter. It's just for immobilization. The kid should not have an x-ray without something protecting their arm. These are neurovascularly, if it's intact, fine. This is one of those few 3 o'clock in the morning neurovascularly intact fractures you call ortho about. Because at 4 or 4:30 or 5 in the morning, they may not be neurovascularly intact. If they're neurovascularly compromised, it really depends on where you work. If you work in our shop, I'm not going to really be trying to reduce this. I'll be calling ortho, and they'll get them to the OR in 20 minutes. If you work somewhere where you're hours away from places, then you may have to call somebody. You may have to try to reduce this, especially if they're vascularly impaired. You may not have a choice. But this is one of the few fractures where if you try to reduce this, you can actually pinch and cause more harm. So if they're neurovascularly intact, leave them, but call ortho in the middle of the night if you have to. In the spectrum of supracondylars, though, that's a type 3 that's knocked right off. This one, you can see that there's an anterior sail sign. There's a posterior fat pad. The radiocapitellar line looks fine, and the anterior humeral line should go through the middle third. This just barely touches the anterior third. And this is typical what happens if you have an angled fracture, sometimes called a type 2, where the posterior cortex is intact. And if you look carefully, there's like a figure of 8. There's not a laser pointer here, unfortunately, but well, you'll see where the arrow comes out here. That kind of is the midpoint of the figure of 8. You can kind of make an 8 above and below on those condyles. And when you see that, this is actually, when you see a traumatic elbow fusion in a child, pay very close attention to that little area where the arrow is, that beak of that figure of 8, or sometimes called an hourglass sign because it looks like an hourglass. It sneaks out the back. This is not an occult supracondylar. This is a subtle supracondylar. The fracture is there. It's just tough to see. This is the kid with the obvious deformity. So again, immobilize these before you send them down to x-ray. And you'll see then there's type 1s where everything's intact, type 2 where the posterior cortex is intact and it's angled, and type 3. So these are supracondylars. Again, look for that lateral line. Make sure you have a good lateral view because it's very important. But there's more to differential diagnosis of elbow injuries, pediatric elbow injuries, than just these two diagnoses, right? This is an 11-year-old kid seen in our emerge by one of our excellent emerge docs. X-rays were done. As you can see, diagnosed as a supracondylar fracture, posterior slab, followed with ortho the following week. So the kid gets immobilized, gets followed up with ortho, comes back to see ortho day 9, and on the x-rays you see the kid was taken to the OR. So what was here that was surgical? In the bottom right, that's the lateral view. It's a good lateral, we're happy, that's fine. But don't just look at the lateral view. If you look at the anterior and the oblique, you can look at the distal humerus, and it actually looks like that distal fragment is rotated off. As you can see on the right shot there, the radial head, which is on the outside, that's lateral, so that distal fragment is rotated. And in kids, yes, they remodel, but only in the plane of range of motion of the joint closest to the fracture. So in the elbow, you have a bit of flexion and extension, remodeling. There's no varus valgus remodeling the elbow. This will never straighten out on its own. And if you have 5 or 10 degrees of angulation at the distal humerus, the hand comes out to the side like this, right? And that's a lifelong deformity that'll never straighten out. The problem is, as kids are growing machines, they're healing machines. So when they come back on day 9, this is starting to get sticky. And if ortho tries to slide it back and push it back in the OR, if the fracture is starting to heal, the growth plate may be the weakest link in the chain. And now when they go try to do a closed reduction, they're going to sometimes injure the growth plate. So it's more problematic. So that's why if ortho sees it day 1 or day 2, the weak link in the chain is the fracture. It's a way easier closed reduction to do. So don't just look at the lateral view. You do need to look at these others. And if there's any hint, if there's any doubt in your mind that it's in perfect position or it needs anything done, the call that you make is not to radiology. Radiology totally mislabels these. They tend to mislabel them. The call you want to make is to the orthopedic surgeon and have a specific question. Not there's a kid that injured his elbow, what should I do? There's a kid that has a supracondylar fracture, I think it's rotated, when do you want to see it? And then they'll give you a specific answer. But they're the ones who are going to wear that clinical decision. Don't ask the radiologist to tell you clinically what to do with it. Another child that fell, injured elbow. Like the main view is the lateral view. These are films done out of our merge that were done. And the 2 views on the right, they're not good laterals. I'll show you why in a second. That they're not properly shot. You should be relatively straight down the anterior aspect and a little more pear-shaped posteriorly. An excellent note is dictated saying that this fracture doesn't require a reduction. That was the emerge doc's decision. But if you look when they come back, they get a proper lateral. And I'll show you, I'll compare them in a second, but this is in the splint. So when they come back within a week, it barely touches the anterior humeral line, barely touches the capitellum, right? But because it's a little, or hard, so actually it doesn't actually touch it. It's pushed behind, so it gets operated on, right? But the other thing is, it's like, what they call, what they're trying to get the laterals on the left view, they're rotated. It's not a nice, it gets sloped down the anterior aspect of the humerus. So you actually have, if you don't have a good lateral, it's easy to miss this. And it's hard to do because the patient's got a sore elbow. But sometimes you just need to adjust and try other ones. Or if you don't have a good lateral, appreciate that you don't have good imaging to make a decision on. And see, these are both very similar views, but they're inadequate lateral views. So you need to have good laterals. And on the AP view, if you look, this again is impacted. So the radial head is lateral. This is impacted again, right? So on this side, it's pushed in. On the medial side, it's pushed in. On the lateral side, it's opened up. This is also rotated. Even if you didn't appreciate it wasn't a good lateral, this is not at all an acceptable position. So this needs to be reduced. So do look at all the views. You probably remember CRITOE from school, and when you heard it, like, okay, that's a neat thing, but what is the clinical significance of it? We're going to spend a couple of minutes and just go over this. So C is capital, and this is the order of appearance of the ossification centers. R is the radial head. I is the internal or the medial condyle. T is trochlea, its neighbor. O is the olecranon. E is external. And the clinical significance really is I and E. So the internal medial condyle sometimes gets pulled off in a 10-year-old or a 12-year-old, either from throwing a ball and torquing on it, or sometimes from falling on it. And like you have an MCL injury of your knee, you can have an ulnar collateral ligament injury of your elbow. And if it's pulled off and it looks sitting down, you may see in this kid that you see capitellum, radial head. In this child, it's normal, but the eye is pulled off, and you see trochlea. So it's important in these kids sometimes to look for this. So this is a kid who's throwing a dodgeball. His medial condyle, again, the eye opposite to the radial. The radial head is lateral. The emerge doc saw this, and that's where the kid was sore and thought that maybe that medial condyle was off. So the emerge doc actually went and x-rayed the opposite side, which was excellent. And when you compare the two, You can see the medial condyle on the right, which is directly underneath the R, looks a little more displaced than the one on the left. So just diagnose with a minimally displaced medial condyle fracture, which is an uncommon fracture. Probably 5% of kids' elbow fractures are medial condyle. And then talked to ortho. Ortho said, no, that's non-operative. You can follow up in the fracture clinic. The kid came back and saw me on day 10. That's exactly where he's sore. We repeated his x-rays. He healed. He was immobilized for another 4 weeks and healed non-operatively. Sometimes, though, that fragment, that little piece, can pull off, as you see it under the R, and can sit near the proximal ulna. And you don't even notice that it's there. So this is why. Look at the age group, 10, 12, 14-year-old kid, medial elbow pain after a throw or a fall. The other one where we get confused sometimes is this. This is a 3-year-old girl who fell off a couch. And when she fell off her couch, she injured her elbow. Seen by the emerge doc sees it and diagnoses as a supracondylar fracture, posterior slab, follow-up ortho 3 to 7 days. This kid was seen on November the 26th. Put in a back slab to follow up with ortho in 3 to 7 days. And the following day, November 27th, the kid has K-wires put through her elbow by noon. But the kid's not supposed to come back and see ortho until 3 to 7 days. And why did the kid have K-wires put through? Because the orthopod on call, the surgeon on call, before he goes to bed, he goes into the PAC system and looks at all the x-rays done in emerge. And he looks at this kid's elbow and says, oh, that's a fracture that needs fixing. Calls the parents. Oh, we just got home from the hospital. Oh, they said you'd call me tomorrow. Oh, I'm calling you today. Doesn't throw the emerge doc under the bus. Why don't you bring your child tomorrow, NPO, to the fracture clinic in the morning. We'll see them and we'll get looked after. That's really, really good care from the orthopod, right? Why do they do it? Because this kid here, this is the next day, this kid actually has a lateral condyle fracture, right? The radiologist calls it a distracted supracondylar. It's absolutely not a supracondylar fracture. Right? There is a large effusion. But what we're seeing, that it looks like an ossification center. But we talk about CRITOE, C-R-I-T-O-E, 1, 3, 5, 7, 9, 11 years of age is when the lateral, the external condyle should appear, not at 3. This is the other way CRITOE comes in handy. So in kids that are typically 4 to 8, 3 is a little bit young, but if they fall, they can shear up. And if you have a lateral condyle fracture that's undisplaced, 20 to 30% chance of non-union if it's anatomically aligned. If it's displaced like this, it's surgical. But this looks like an ossification center. It's easy to miss. You can see it on the other views. And yes, there is a proximal humerus fracture, but you've got to be careful of lateral condyle fractures. That's maybe 5 to 10% of pediatric fractures in kids 4 to 8 years of age, and it looks like an ossification center, but in kids, the lateral condyle shouldn't appear until they're 11 or 12 years of age. This is commonly missed. The number of times, I tell you, in 2,000 shifts, I diagnosed a lateral condyle fracture is zip. I never knew it existed as a problem. And the last case, this 11-year-old kid that fell. Again, kids, it's not just supracondylar. This kid has a radial neck fracture. And what happened was seen by an excellent emerge doc, diagnosed as a radial neck fracture, slab follow-up with ortho, comes back to see ortho the next week. This kid was seen in emerge on a Tuesday, follows up next week. It was a Friday, that's when the orthopedic surgeon's clinic was. So 10 days after injury. And the orthopedic surgeon shows me the case. He goes, can I show you a case? I'm like, absolutely. He says, you see this here? That's a radial neck fracture. The ice cream is kind of pushed off the cone. He says the problem is the radial neck is involved in which movements? Pronation, supination. So he says now if I saw this day 1 or 2, I would push this back up. But now I see it day 10. Whether I do an x-ray or not, there is callus around this. If I try to push on this, the weak link in the chain is going to be the bone. So I have the growth plate rather. So I have no choice but to leave this. And there's a 50-50 chance this kid is going to have problems with pronation, supination. And if he has problems with pronation, supination, the only fix for the kid is not going to remodel. This will never remodel. It's not in that plane. The only fix for this is an osteotomy. Now, an open procedure, break bone, realign it, and put a K-wire across it. So instead of just a closed reduction and pushing it up, now it needs an operation, which is way more significant. He says, so this is the point of that if it's out of position, if you're not sure, just ask somebody. If it's 2 in the morning, you don't have to call. At 7 in the morning, say I sent the patient home, this is their phone number, are you happy with the position? Or if you're worried about the follow-up for the patient, keep the patient in overnight and sort of see if it needs to be done. But if you're not sure if the position is acceptable with kids, don't just ship them out to be seen in a week, because the kid's healing that fracture in a bad position for a week. So be careful, it's not all supracondylar. So this is the last case, a dislocated elbow in a child that I saw. We reduced it, but that is the medial condyle that's pulled off. And if a kid ever dislocates the elbow, that means the ulnar collateral ligament got injured, and in kids, it means they pulled off the condyle. So it's an uncommon injury to see a dislocation in a child, but there's the medial condyle. When it got reduced, that medial condyle is still sitting off. And I wasn't sure if that position was acceptable or not, so I called ortho, and they said, yeah, we accept 5 to 10 millimeters off the medial side. The lateral side, no shift at all is allowed. So this was treated non-operatively. But if a kid ever dislocates their elbow, a pediatric case, almost for sure they will pop off. They will pull off their medial condyle. That's this. So, supracondylars, pulled elbows, you've got to add to your list medial condyle, lateral condyle, radial head, dislocation. Just as Lior and Sean were talking before, there's common things, but it's, what you get paid for really in Emerge is to pick up the uncommon ones, the needles in a haystack, right? That's what you're there to look for. Uncommon injuries are commonly missed. How do you pick them up? Be careful. Don't rush. Be careful and don't rush. Take your time with kids and elbows. They can be really tricky. Thank you.